Hello guys, hope you're all doing well. Today I have come back with a most important topic as far as part 2 and part 3 MRCOG exams are concerned, which is a sexual assault. Sexual assault is much more common than what we think. In fact, 1 in 5 women between the age of 16 to 59 years have experienced the sexual violence at some point of time in their lives. As healthcare professionals, especially obs-and-gynae doctors, it is we play a vital role in providing not just the medical care but also the compassion and the patient safety. In today's session, I would like to tell you how to handle this stations with more empathy and sensitivity. Before we begin, I just want to tell you guys there is a great TOG article on this particular topic, which is a sexual assault. Please do check it out and give it a read. And it's not updated since 2017. Cases involving this sexual assault or violence usually comes in different variations in the RCOG curriculum. The college often asks these stations because the college wants to assess how well the candidate can handle these sensitive topics, knowing the basic legal formalities or the considerations, your communication, the confidentiality you maintain, and the professional conduct. And I won't be covering the child sexual abuse or an exploitation station here because that requires a separate discussion, and I will be uploading that video on a later point. So as we have discussed, this particular topic can come in different variations. It can come as a structured discussion or a simulated colleague task or a simulated patient task. As far as your simulated colleague task goes, usually you might be told like your junior colleague, say for example ST1 or ST2, has seen a victim of a sexual assault in A&E, and she has taken the history and she has done a preliminary examination and she has put a diagram of the injuries as well, and now she has come to you to discuss about the further management, and she also wants you to look at the diagram she has put and comment on that. That is something you guys can expect in a simulated colleague task. And as far as the simulated patient task goes, you as a ST5 being called in A&E to see a 15-year-old girl who has come to A&E following a reported gang rape, something like that. Or you can even encounter an adult patient as well who was a victim of the sexual assault. Or you can get even the structured discussion. Let's quickly look at our today's learning objectives. Most important is how to take a sensitive and a respectful history from someone who has been sexually assaulted. That is something very, 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 very important. And the next objective is what immediate steps to take, both medical and the forensic aspects. And our third objective is to ensure the safety and the support, especially when the child or a minor is being involved. And we should be well aware of the documentation as well because this has got a legal importance. Let's begin with first things you must do when a patient comes to you after a sexual assault. The very first you walk in such stations is to ensure the patient is safe. This step is not just to ensure she is physically safe, but this is where your marks in this OSCE lie. Your examiners are watching you, the way you talk to the patient, the way you're showing your empathy towards her, the way you're trying to gain that trust right from the beginning. That is why I always tell students, do not rush into the clinical questions, especially in these sensitive stations. All you can do is that start with a compassion, acknowledge her trauma and offer her the right support. Your Tone, body language, and the choice of words matter as much as what you ask the patient. This is why I have given you some example statement how you could tell in the exam. This is just an example. You can try your own words, whichever is suitable for you guys. You can tell something like, "Hello, I'm Dr. Deepika. I'm really sorry we are meeting in such difficult circumstances. My team has told me a little bit about what happened. You're safe here and I'm here to help you. You're not alone. Is there anything you need right now? Would you like me to call someone to be with you? Yes, that is all you need." And for the minors, you can ask something like, "Are you here by yourself today? Would you feel more comfortable if I called your mom or a dad or someone close to you?" Usually, the minors wouldn't like involving the parents. In such scenario, you can ask if she has got any siblings or friends whom you can contact. The second step is maintaining the dignity and the confidentiality. This is an essential part of your OSCE marking scheme, and it starts the moment you walk into the room. What do you mean by maintaining a dignity? It just means giving the patient privacy, respecting her space, and not rushing or judging her. Always do not start questioning her, especially the clinical questions. The confidentiality means it clearly tells you need to clearly tell her that whatever we discuss here today will remain confidential. It will be kept private. Unless there is a risk of harm, in that case, we are required to involve safeguarding. So that will take care of your maintaining the dignity and the confidentiality. Before you continue any further with questions or the discussions with the patient, always stop and ask, is she in pain right now? Or is there any active bleeding or any injury that needs an immediate care? This is the most important patient safety point. And you can't afford to miss this in an exam because that might make you get a borderline or a fail point in the patient safety domain. And so do not continue with history or a safeguarding straight away. Pause and address any physical needs first. If she is in pain or a bleeding, that comes before everything else. So once you have ensured her safety, maintain the dignity and the confidentiality, and you can ask something like, before we go any further, I just want to check, is there any pain or bleeding that needs to be addressed immediately, or is there anything else you want me to help you with immediately? This is one of the most commonly overlooked OSCE points. Always involve a senior or a consultant in the decision making. It can easily earn you marks under the domain of communication with the colleagues. At some point, I would not say like you have to involve in the beginning of your consultation or towards the end of the consultation, but just to make sure at some point during your consultation, make sure you clearly say something like, I will discuss your case with my senior or a consultant and take their input before we move forward. You're not expected, you're only ST5, you're only a trainee, and you're not expected to manage this case on your own. So acknowledging this by saying that you would involve your senior consultant shows a safe and a collaborative approach you have got towards this case. Sometimes the patient may be in a denial mode, or she just wants to leave. She's not listening to you. All she wants to do is leave from here. What you should be doing at that point of time and how do you tackle the situation? It is completely understandable, isn't it? She is traumatized, but not addressing this is a serious patient safety point issue again. So you need to gently acknowledge her feelings and also explain why we can't skip this medical care at this stage. and how one can address this. So you can tell something like, I understand this is a lot to take in, but women in situation like yours, we need to do a proper assessment and give certain emergency medicine to make sure you're safe. I don't want to keep you any longer than necessary, but I really need you to bear with me just for a while. Whatever you share with me stays private unless there is a serious risk to your safety. When you approach with such an empathy and a gentle tone, patients are usually willing to cooperate and you can proceed from there. So now you have reassured the patient, you have been maintaining that confidentiality, the dignity, you have reassured her about the safety, and you have taken the permission to proceed forward, isn't it? Now she's all ready to move forward. And now your job is to take a more respectful and a sensitive history. I always tell the candidates to ask an open question. By doing this, the biggest advantage is that the role player end up telling everything, all the history in one go, which is in fact very advantage for the candidate. It saves time and you will avoid asking multiple questions. But when you ask an open question, the role player will end up telling everything in one go, but you need to pay a full attention there. If you're not paying a full attention there, and if you ask a question which she has already covered, then she will be like, doctor, didn't I tell you earlier? So that looks little awkward in the station. So when she's telling you all the story, especially in the beginning, pay a full attention. Having said that, you then continue to ask other questions she has not covered for your open question. So what kind of assault was it? Whether there was any penetration, was it a vaginal, anal, oral, or penetration using any object or a weapon? So those things you guys have to take care of. And the time and place of the incident, when did this happen, where did this happen, this incident happened, and were there any multiple perpetrators? This is particularly important in a suspected gang rape. Then whether the attacker is known or unknown to the victim. If it's a known victim, then you have got set of questions to ask. And did the perpetrator threaten her or used any weapons? Was there any mention or acknowledge of condom usage? That is something you guys have to ask. And in the context of an assault, whether she was under influence of an alcohol or drugs. Because in the talk, there is a beautiful line. The drug facilitated sexual assault can be opportunistic. So if she has been given drugs or alcohol, then something like this has happened. So that is something you guys have to inquire. And whether she has eaten or had any drinks after the incident. Did she change the clothes, or is she in the same clothes after the assault? So these are the basic questions you guys are going to ask. And other relevant history, history of STIs, contraception usage. This is particularly important if she is on some contraceptive pills, combined oral contraceptive pills, or progestin only pills, or if she's using a copper coil. This is important, especially when you are offering her an emergency contraception. So you need to ask that. If she says that yes, I'm on regular pills, then it is important to understand how well she's adhered to the medication, whether she's taking it regularly or not. All those questions would come. Then whether she has got any past medical conditions she sees her GP for, any medications, especially the enzyme inducing drugs. Say for example she's asthmatic or she has got epilepsy, she must be using some enzyme inducing drugs. So if the victim is where you have to prescribe an emergency contraception, especially the oral pills, and then if she's on the enzyme inducing drugs, that's going to impair the metabolism of these drugs, isn't it? So that is why it is important to ask if she has got any medications which she uses on a regular basis, and then any mental health concerns in the past, and at the moment how she feels at this point of time, because she's been traumatized, she's been assaulted. So at this point of time, how she feels, does she feel like harming herself, or any thoughts as such, or any suicidal ideations? That is something is very, very, very important patient safety point. And any history of previous abuse or trauma. BMI is relevant again if you're prescribing an emergency contraception. And her menstrual history, of course, again, if she is a child, ask whether she has attained the menarche. Do not skip and do not jump into asking questions like whether she has got regular cycles and when is the last menstrual period. And it shouldn't look like, doctor, haven't had my menarche yet, right? So it is again based on the age. Ask about the menstrual history as well, which is particularly important while you're prescribing an emergency contraception. Knowing her living situation is also extremely important. Who does she live with? Is there any known perpetrator living with her? Why I'm saying this is that you guys have to ask about a living situation is there are vulnerable populations and who are at high risk of the sexual assault, especially the women who are young, or the women who are poor, living in some social housing, in some poor health, if they are single or separated or divorced, transgender women, young girls who have got some learning difficulties. So these are some vulnerable groups where you may have to provide an additional support there. So that is why it is important to know their living situation. And why I'm saying any known perpetrator living with her is the sexual abuse is often a form of domestic violence. A serious sexual assault is most likely to be committed by someone known to the victim. In the talk says in 89 to 90% of the women, it is by someone known to the victim, and in about 50% it is partner or the ex-partner who has been the offender. It's a different topic. I am going to cover this when I talk about a domestic violence, where you need to involve a MRCOG referral, which is a multi-agency risk assessment conference meeting, things like that. So which will be a later discussion. So that is why sometimes all these things can be clubbed. It could be a chronic abuse, it could be a domestic violence. So that is why these topics are usually overlapped. So just be aware, be mindful about asking this living situation. So now you have completed the history. Now it is very important to show the empathy and reassure her once again. Let her know she's not alone and we have the support available, and we can connect her with a trained counselor to help her cope with this situation. And if she feels comfortable, she can involve someone she trusts. It could be a friend or a parent or a family member to support you through this. So I have just given you some example statement how you can tell this to the patient. That would be like, I understand this must be a very difficult time for you. You're not alone. We have support available. We can put you in touch with one of our trained counselors to help you cope. We also encourage you to involve someone you trust, like a close friend, a parent, or a family member to support you through this. If the patient is an adult, she's 18 or above, then ask her, would you like to report this to the police? If yes, well and good, proceed with explaining the next steps together. If no, again reassure that that's all right. Can I ask why? Ask her why she doesn't want to complain it to the police. Is it because she feels unsafe or threatened in any way? If Just tell her that if she feels unsafe to go home or she's being threatened, we can still help her. we will alert our senior consultant and offer you an admission here. Involve our safeguarding team as well, including the child safeguarding team wherever it is applicable, wherever she thinks her children are also at risk, to make sure you and your children are safe. So it is again, it depends on the situation, what task you're dealing with. Is she an adult, is she a minor, and whether it is a known perpetrator or an unknown perpetrator. If she thinks she's unsafe or she thinks the children are at risk. So it depends on the situation. You have to do some variations and go about it. If you are dealing with a patient who is a child or a minor, then it is our duty to involve a safeguarding team and the police, irrespective of the things, to help protect that child and also to make sure that she is safe. So in an adult, you always encourage her to do so, and you always offer her an admission, involve a consultant, involve a safeguarding team, police if she wishes to. But in a child, we always involve a safeguarding team and the police. The reason why I have put this slide is that I want all of you to be aware of this situation you might encounter in a sexual assault station, where the patient declines the police involvement or even the examination for that matter. Supporting autonomy after sexual assault is very important. It's her choice, it's her rights. But we need to support her without pressure. We need to give a justice to our job. We need to give her all the information she needs, and we have to tell her what we can still do about it. This is why I have given you some example statement how you can talk to her in this situation, especially when she denies an examination or complaining it to the police. I completely understand that you may not feel ready to talk to the police or go through an examination right now. It's absolutely normal to feel this way. Having said that, I do want to let you know a perpetrator like this should be brought to the justice so that this doesn't happen again to you or to anybody else. But at the end of the day, it's your decision and we fully respect that. One thing I would like to offer, if you're okay with it, is that we collect this time-bound evidence now, such as swabs or DNA, and store them securely so that if you decide to lodge a complaint later, you can still have this evidence with you. You don't have to decide anything right now. We can go at your pace. I'm here to support you with whatever you choose. So this is something you guys are going to tell her. And when you should offer her a forensic medicine team involvement or an emergency evidence kit. So continue to explain her about the options she has got. So we have a forensic medicine team, we have got an emergency evidence kit. So how you should be explaining that to her. So tell her, if you're okay with it, if you feel comfortable, we can involve our forensic medical team. They're specially trained to support in situations like this. They carry out a full forensic examination if you're ready for that. However, if you're not comfortable with a full examination right now, that's absolutely okay. We can still offer what is called an emergency evidence kit here in the hospital. It includes collecting only certain items like your clothes, urine sample, and a few swabs without needing a full examination. We do have the kit available right now in the emergency department. If you're okay about it, we can do that. That is something you have to tell her. If she is agreeing for a forensic medicine team involvement, then you have to tell her that few things, like she should not be washing or wiping, eating, drinking, or passing urine until the forensic team has assessed her, and tell her that you're going to document everything about her history, examination findings, because that is an important legal document. So coming to the emergency management or an immediate care you are going to offer her, which is very, very, very important as far as the patient's safety points are concerned. Emergency contraception, if applicable. The talk says the vaginal rape carries a 5% risk of pregnancy, and if women becomes pregnant after an assault, will have physical and psychological complications. Therefore, we need to give an utmost consideration to this pregnancy prevention. Again, it depends on whether a victim is on regular contraception or not, what is the timing of her menstrual cycle, and you need to assess that in your station, and depending upon that, whether she is a candidate for an emergency contraception or not. Women should be offered all methods of emergency contraception. You don't have to tell this what you're going to offer her. Is it the pills or the copper coil? Copper coil is the best one, but it's out of scope topic in here. You just have to tell her that we have to offer you the medicines or the copper coil to prevent the pregnancies, because there is a 5% risk of carrying pregnancy. So that is something you need to tell her. And second thing is that HIV post exposure prophylaxis post sexual assault. This is something needs to be discussed with women, with every woman. Of course, there are cases which puts women at highest risk, say for example unprotected anal intercourse, or if a perpetrator who is a known positive HIV status, or there is an exchange of the body fluids, or there are some genital injuries, or it's a gang rape where the multiple assailants are involved. So all these are the risk factors where it puts a woman under high risk of HIV. However, we offer this to every woman, and this is something is not we are going to start. Usually we refer them to the gum physicians, and they are going to assess the risk, and they are going to start. And this has to be started as soon as possible, or preferably within 72 hours, and we continue it for 4 weeks, and with a referral to the gum clinic. So that is something you guys have to discuss with her. And the third thing is that to prevent other infections like hepatitis B, we offer her the vaccinations right now, usually on a fast track regime at 0-1-3 weeks or 0-1-2 months, with a booster dose given at 12 months in either the course. So these are three most important emergency management or an immediate care you are going to discuss with her. Coming to the follow-up, as far as this particular station is concerned, is very crucial. When should you refer them to the gum clinic? I have already told you that for an HIV prophylaxis, yes, we are referring them to the gum clinic, because the gum physicians are the one who are going to decide about it. Other than that, the timing matters, because many candidates make this mistake of saying they will do the STI screening right away. Unless she is a high risk behavior candidate, you're not going to do any swabs at this point of time to rule out STI. That swab is different what we have spoken, which is for the DNA evidence, which I'm going to discuss with you guys in the upcoming slides. These swabs to diagnose STIs has got a specific timeline you guys have to follow in a post-sexual assault cases. The serological test for the HIV and the hepatitis B and C will be done at 3 months after the assault. If necessary, you can do it as a baseline test and then repeating it after 3 months. But do remember, if she is given this HIV prophylaxis, then we do it after 4 months. All right, 3 months and 4 months. 4 months if we have started the post-exposure and post-assault prophylaxis for her. That is something you guys have to remember. And the swabs for the STI, we do it at 3 weeks after the incident. So 3 weeks and 3 months, you need to remember. It's not immediately we are going to do it. And at this point of time, we can even do the pregnancy test wherever it is necessary, if she has missed her period or something like that. Mention her that SARC, What is SARC? SARC is a sexual assault referral center, isn't it? It's a model. You have got a list of SARCs across the UK. So mention her that SARC is something which will help her in the forensic examination, immediate aftercare, like emergency contraception, the prophylaxis against the infections like vaccinations, even the follow-up services, screening for STI, psychological services. Sometimes the SARC even offer a forensic examination and help in collecting the evidences without even the police being involved. So there are more than 40 SARCs operating throughout the UK. So the SARC is the one which does everything from right from the beginning to the follow-up. That is something SARC is going to take care of everything. All right. So tell her that we involve the SARC, which is a referral center, which will take care of everything. All right. At the end of your consultation, don't forget to mention the support groups. You have got n number of support groups. The most important one, SARC, we have already mentioned. Other than that, you have got adult and child safeguarding teams, which also you have mentioned, and Rape Crisis England, Safe Lives, Women's Aid. There are independent sexual violence advisors, ISWA. Remember, there are more than 80 independent sexual violence advisors. They usually work along these agencies. They work along SARC. They work alongside the doctors, nurses, health advisors, and counselors. So you can mention about them as well. So it is. I know it's difficult to remember all the names, but you can mention few. SARC, anyways, you are going to mention the adult and child safeguarding services. You are anyways going to mention. Other than these, you can remember one or two names. All right. If you don't remember in the exam, it's absolutely normal, because in that exam tension you tend to forget the names. But just do remember that we have got specific support groups available for a woman who has gone through the situation like yours, and we can give you the written information on that, so you can tell like that as well. If you remember it, tell it confidently. It shows that you are providing a holistic care, and it will also helps you score communication and patient safety marks as well. Emergency preparedness kit. Well, this is something I usually cover in a domestic violence scenarios. But it is equally important in sexual assault cases, because I told you it is often seen in a domestic violence. The sexual assault, especially the serious sexual assault, are seen in a domestic violence cases, especially if the perpetrator is known to the victim and she feels unsafe. So we should gently advise her to keep an emergency kit available in case she needs to leave home quickly. And always let the patient know that we can help her plan this, and we can give her information about the safeguarding teams if needed. Okay, and the kit generally should include the basic things for an emergency evacuation plan. Her identification proof, important documents, if she's on any regular medication, some cash, emergency contact numbers and local helpline numbers, the pair of clothes, extra house or car key. So that is something you guys have to tell her. All right, if you do not have time, just mention very important points, that in case if it's a known perpetrator and if she feels unsafe and she has to leave the house immediately, if there is a threat to her, then always keep some emergency evacuation bag with some cash, pair of clothes, and emergency contact numbers, things like that. So that completes your patient simulated task. If you are given a patient colleague task, then these are some extra points which I want to tell you guys, so that we will cover the entire sexual assault topic as a whole and you will not miss out on anything. Because this is extremely important, because you need to explain them everything. You need to explain them how you should be taking the history, and how you should be doing an examination, how you should be doing the diagrams. So that is why these points are extremely important. So any injuries should be treated with a basic first aid. I told you guys, if there is any active bleeding or there is a pain, we will address it. But remember, if it's a minor injuries that do not require suturing, you should not go and keep cleaning them, because this is these because the samples can be taken from these sites for the DNA evidence, and you shouldn't be destroying the evidence. That is why. And it is possible to photograph the injuries. For that, we need consent from her. And if the police are involved, then they will involve the trained specialist to photograph, to take these non-intimate images. And after forensic medical examination, a digital camera can be used, and sometimes we use a colposcope to document the genital injuries. This is just for your reference, what you should be doing with the injuries. But as far as your colleague simulated task is concerned, you need to explain them in much detail about a documentation, much detail about the diagram that has marks for your applied clinical knowledge. So documentation in sexual assault, the key principles are that we always document exact words used by the patient. We call this something like verbatim documentation. That has to be in same words stated by the victim. You should not be changing it. Keep the language clear, factual, and non-judgmental, and these notes may be used in the court proceedings later, and they must be precise and defensible. And poor, vague documentation can weaken the forensic evidence, and this should include the patient details, the date and time of an examination, name of the person who examined it. And as far as diagrammatic documentation is concerned, you need to tell your colleague or junior doctor how she or he should be doing the documentation. So for each injury, they have to record the following. Usually you will be given a diagram which is drawn by them, which is not exactly how it is supposed to be, and that is why you have to talk about this. So you need to mention the location, shape, color, type of injury. They usually do not mention these medical words like laceration, abrasion, or hematoma. So you need to correct that and tell them. Size, tenderness, and you need to use a full body diagram to mark the injuries, and you need to mention the measurements from a fixed bony landmark. Say for example, 1 cross 3 centimeter purple bruise 5 centimeter above the left knee joint. So this has stated size and the color and type of injury, and the location, and also the measurement from a fixed bony prominence. And we need to label the injuries in a clockwise manner. That means it's a 3 o'clock position, 3 o'clock perineal tear, 5 o'clock perineal tear, something like that. And note both the positive and the negative findings. If there is no bruising over the limbs, you document. So you need to document not just the positive findings but also the negative findings. This is again for your structure discussion or for a colleague simulated task if they ask you what does the early evidence kit, because you are not going to explain much detail to the patient in a patient simulated task. But for other stations, yes, you need to remember this. This early evidence kit is available in the emergency department. It's a sealed a cardboard box, and it contains a plastic pot for the urine sample, and it has got a toilet paper sample, a mouth swabs, and a mouth rinse, and also there are some instructions on how to use the kit. Remember, the contents may vary, but the minimum requirement is urine collection and a mouth rinse. Why the reason behind the way it has put up is urine sample increases the chances of detecting the drugs or alcohol that may have been used to facilitate the sexual assault. That is why the urine. And mouth rinse sample, again, we might detect a vital evidence where if there is a oral penetration. And again, the contents of the kits may vary, but we need to remember the minimum requirement, which is a urine collection and a mouth rinse. This is again useful for part 2 exam candidates and also for a structured discussion, or if particularly a role player in the colleague task asks about these questions. As far as a forensic evidence collection, yes, key timelines are there. The buccal swab is the reference DNA sample we are going to take using a buccal scrape from inside of the women's cheek. And other swabs is again, timing is based on the type of assault. If it is a vaginal penetration, swabs can be taken up to 7 days after the incident. If it's a anal, then up to 3 days. If it's a oral, then only 2 days. And for the toxicology screening, if you are suspecting there is a drug facilitated assault, then you have to collect the blood sample within 3 days, and urine sample can be collected up within 14 days. Not very, very important for part 3 MRCOG exam, but yeah, for part 2 it is important. The Sexual Offences Act 2003, which is applicable to the England and Wales, defines the sexual assault as any person who intentionally touches another person, or the touching is sexual, or the person doesn't consent, then it is called a sexual assault, and the maximum prison sentence for this is 10 years. And the serious sexual assault is when a person commits assault by penetration, that is, they intentionally penetrate the vagina or the anus of another person with a part of the body or anything else without the person's consent. So the definition of rape is where there is a penetration of the vagina, anus, or mouth of the person that has occurred with a penis without consent. So the maximum sentence for this is a life imprisonment. So some laws you guys have to be aware. And this is an extremely important slide, I would say. The law regarding the sexual assault in the UK, the age to consent to any form of sexual activity. This is particularly important not just for this particular station. You might come across various stations involving an adolescent, and where you would think whether it's a criminal offense or not, whether to involve relevant points or not. Why I'm saying this is the age of consent to any form of sexual activity is 16 years in the UK for both men and women. And it is an offense for anyone to have a sexual activity with a person under the age of 16 years. But the parliament thought this is unnecessary, or for the criminal law to intervene where it was wholly inappropriate. Say, for example, they are under 16 years where they have mutually agreed and they are of similar age group. This is not considered as a crime. This is particularly important when you're handling those adolescent cases, when you're asking about relationships. Always inquire about the age of the partner. What is the age gap between these two? If it is more than or equal to 4 years of age, then it raises a concern. Is it a grooming? Then we need to explore it further. If she is like 15 years, she is in a relationship, and the guy is also from the same class, then it is nothing much about it. Shouldn't think like it is some sexual abuse or a exploitation case. We will cover this in detail during sexual exploitation station, which I'm going to do next. The Sexual Offences Act 2003 provides a specific legal protection for children aged to 12 years. Under 12, no matter what, even with or without the consent, it amounts for rape. Sexual abuse is sadly more common than what we think. It is extremely important for us, being obstetricians and gynecologists, because we encounter such women who have experienced the sexual assault in their lifetime, recently or in the past. This is a sensitive topic. This is a difficult topic or very uncomfortable topic to discuss, but we need to raise above that. Just one compassionate question from us can open the door to someone who can actually speak up about the things. Whether you are in an OSCE station or a real life in the busy clinic, always lead with empathy and let every patient know they are heard, they are safe, and they are not alone.